Welcome, everyone, to the July presentation of the Rehabilitation and Movement Sciences Grand Rounds presentation. Please utilize the QR code to log in for EADS. It's also pasted into the chat. Today we have Dr. Michael Steimling. Dr. Steimling is an assistant professor in the Doctor of Physical Therapy program at Moravian University and is the primary academic faculty for the musculoskeletal series. He received his Bachelor's of Science from the University of Pittsburgh with a major in exercise science and his Doctor of Physical Therapy from Drexel University. Dr. Steimling has distinguished himself as a clinical expert in sports and orthopedic rehabilitation. He has been an ABPTS board-certified clinical specialist in orthopedics and a fellow of the American Academy of Orthopedic Manual Physical Therapists since completing the fellowship in orthopedic manual therapy from Regis University. Dr. Steimling has clinical expertise in an orthopedic and sports physical therapy setting and has a special interest in the management of running-related injuries. His research interests include running biomechanics and its relationship to running prohibitive conditions and the use of gait retraining in managing those conditions. I will now turn it over to Dr. Steimling.
Thanks, Jeff, for that intro. My name's Mike Steimling, and I'm excited to be able to talk to you about some running-related topics today. So this is our statement of need, and this is our designation statement. And I would like to disclose that I have nothing to disclose. So some of our learning objectives today, goals today are to look at some kinematic variables that are related to injury, and then look at individuals that might benefit from gait interventions, as well as some strategies that we can use to implement those gait interventions. So we're going to start with our obligatory but background slide. So why running? So we know that running is an incredibly popular form of exercise and recreation, with an estimated 50 to 60 million runners nationwide. About 45 million of those are competing in a race every year. We also know that just running 20 to 30 minutes 2 to 3 times a week is going to exceed the ACSM physical activity recommendations, and it's also a prerequisite for most sporting activities. My wife made fun of me when I included this last bullet, but I couldn't help myself because I'm a bit of a running nerd. But are humans running people? There's an excellent review article that came out in 2004 by Bramble and Lieberman, where they explored many of the human traits that we have that allow us to be excellent endurance creatures. Actually, maybe some of the best within the land-bearing animal kingdom. Including long Achilles, a decoupling of the locomotor respiratory systems, and an extensive network of sweating glands. Theories like this have been further popularized by the Born to Run book by Chris McDougall. This book's a little bit older now, but if you're interested in running-related topics, it is a great read. Many of his theories, the science still hasn't necessarily caught up to, but there's some interesting things here. So moving forward, I would like to talk a little bit about running and musculoskeletal health. In 2017, Dunleavy did an interesting study where they looked at MRI results of individuals running at various distances in sedentary individuals. And what they found was that individuals who ran more than 50 kilometers a week actually had higher or larger intervertebral discs. And 50 kilometers a week is about 31 miles a week. And then individuals that ran 20 to 40 kilometers a week actually showed signs of increased disc hydration. And so they postulated that the repetitive loading cycles that we see in runners may be a mechanism which facilitates arguably a healthier spine. Additionally, a commonly held belief is that running is bad for our knees. However, the evidence may not support that belief. What we see in a systematic review in 2017 is that there's actually a lower prevalence of osteoarthritis in recreational runners, 3% versus 10%. Additionally, another systematic review found that running was actually protected against total knee replacement. And there might be multiple mechanisms at play here, but I think it is interesting because it starts to shift the narrative here that osteoarthritis may not be a condition of wear and tear, but maybe more of a loss of intra-articular homeostasis, and that physical activity, including running, may be actually a part of maintaining that homeostasis and potentially even restoring it. This is actually something that our lab is looking to investigate in the near future. So moving forward, we do see that despite all the good things, that running injury rates are high. These first two papers I included here because they're highly cited within the literature, and we see a relatively high incidence and prevalence of running injuries. A more recent systematic review found that, slightly more conservative numbers. However, I do think that they're meaningful. A study that we just completed looking at cross-country runners, we found that about 50% of runners suffered a moderate or severe injury within a 9-month running season. So this lines up pretty well with the last paper there. So when an injured runner comes into my clinic, some of the things that I want to know about, first off, the nature of that condition. And so the what, the where, the when, is this the first time or the 8th time that you've experienced these symptoms? Additionally, I do think it's important that we still recognize our role as medical screeners in this population. Obviously, they're often exceeding physical activity requirements, and so we may label them as low risk. However, we do know that cardiovascular risk factors are still going to exist in this patient population. And we know that other conditions like relative energy deficiency in sport is highly prevalent within this population. And we know that it could be relevant to their current complaints, but also that we know that it may have long-term health consequences, specifically when we think about females and their long-term bone health. Additionally, Mattson in 2022 found that psychological variables, most notably anxiety, was heavily related to delayed recovery from running-related injury. So again, this supports this idea that we need to be looking at the patient as a whole and not necessarily just what they're coming in for. And then also I want to know about their running habits. I'm a bit of a running nerd, so I often ask these questions because I like to know about people's training habits, but it also gives me a lot of good clinical information. So we look at running volume, how often or how much are they running, 5 miles a week versus 40 miles a week, the intensity of that training. If they're a trail runner, they might be doing a lot of elevation training. If they're a road runner, they might be doing a lot of speed work or threshold work. What are their goals? Is this their first 5K or their 10th marathon? And what types of terrains are they running on? Trail running may look a lot different than road running. Changes in any one of these habits or variables may be related to a running-related injury. So what do I examine? Well, first, I'm going to start with range of motion. When we look at running, for the most part, it takes place within the mid-ranges of our range of motion. So it may not be required for them to have full range of motion, with the one exception of the foot and ankle, where we like to see, or at least like to see above average dorsiflexion and great toe extension, depending on their shoe wear. Additionally, I like to look at strength, and I break these areas up into 3 categories. Impact attenuation, which is the quadriceps, the tibialis anterior, and your heel strikers and the gastrocsoleus complex. Your propellers, which is mostly your posterior chain, your glute max, the hamstring, gastrocsoleus complex, and then your stabilizers, so your glute med and your glute max mostly. However, we may also consider looking at the tibialis posterior. I really do advocate for the use of a handheld dynamometer in this patient population. I think it does give us really great objective numbers that we can track over time, as well as with a patient population that is often goal-oriented. It allows us to establish really nice, clean goals. And lastly, I like to look at videos. They're there. Lastly, I would like to look at movement control, which for the most part is going to be a 2D gait analysis. With the 2D gait analysis, we are going to be looking from a posterior view, which allows us to have the frontal plane mechanics, and the sagittal view, which allows us to look at the look at the lateral view to look at sagittal plane mechanics. And from this, we can derive 2 things, their movement control, or their ability to control their body, and then also look at the impact and how they attenuate impact. I mostly look at movement control within the frontal plane, and I look at impact within the sagittal plane. So with running, we know that running is going to be an impact activity. And so with running, we see impact in 3 axes, anterior, posterior, medial, lateral, and vertical. We do see substantially higher forces in the vertical, and so that's what we're going to talk about today. Ground reaction forces peak around 2 to 3 times body weight, around 50% of the way through the stance phase. This is known as the active peak. Additionally, we see another peak, which is known as the impact peak or the transient peak. And this is the peak that we see from the heel hitting the ground and then the foot flattening out. And then lastly, we see something we refer to as loading rate. And this is the slope of this line leading from initial contact to the impact peak. And this is essentially how quickly we see the forces in the vertical direction. All 3 of these variables have been connected with injury or are thought to contribute to injury. So 2 variables or 2 kinematics that I look at within the sagittal plane is the foot strike pattern. We have a rear foot strike pattern, also known as a heel striker, and then the non-rear foot strike pattern, which is going to classify both the midfoot and the forefoot strikers. There's a lot of debate over the last 10 years about which one of these strike patterns may have benefits for both injury prevention and performance. For the most part, the literature still seems to be a little inconclusive on this. But what does seem to maybe be important to look at is this foot inclination angle, which is the angle from the running surface to the bottom of the shoe, which would imply that the larger that angle is, the more your toe is pointing towards the sky or towards the ceiling. And the bigger this angle is, the more we see, or the larger the impact forces that we see, because it takes the foot longer to go from heel strike to the foot flat position. So most of the discussion around the differences in foot strike and the relationship to injury is related to these loading curves. What we're going to see here is that in the rear foot strike on the left, we see a transient peak. On the forefoot strike, we see that transient peak actually disappears. Additionally, we see that on the loading rate, which is the slope of the line highlighted, that on the left, it is much more vertical, implying that the individual is seeing more force more quickly. However, on the forefoot strike side, we see that slope actually starts to level out a little bit. So this is thought to actually reduce injury risk. However, that hasn't necessarily boiled out in the literature. So when I look at sagittal plane mechanics, I look at foot strike, which we've already discussed, but additionally, I look at a couple other variables that are related to stride length. First, I look at knee flexion. At initial contact, we like to see more knee flexion with the idea that it better places the lower extremity in a position to attenuate force, and most notably the quadricep. We also look at tibial orientation, which is how vertical the tibia is. We like to see the tibia more vertical if possible, with the idea that it's going to help bring the foot closer to the center of mass. And then lastly, we look at the foot placement relative to the center of mass. The closer this is, the smaller we see impact forces seem to be. Additionally, we look at something known as cadence. And cadence is the number of foot contacts an individual makes in 1 minute. And there's an inverse relationship with cadence and stride length. So the faster your cadence or the higher your cadence, the shorter your stride length. And we'll talk more about that in a second. So here's an example of 2 runners that I evaluated for hip pain. On the left, we see this individual right before they hit the ground, and they are landing with a relatively flat foot, a forefoot strike in this case, a relatively vertical tibia, and probably about 20 degrees, 25 degrees of knee flexion, and their foot is landing relatively close to their center of mass. On the other side, on the right side, we see the individual is landing with a heel strike with a relatively large inclination angle where their toe is pointing relatively high into the air, a tibia that is extended or non-vertical, and a knee that is also extended, probably roughly 10 degrees. And then a foot contact that is relatively far away from their center of mass. When I evaluated these individuals, the individual on the left responded well to just strengthening interventions. And on the individual on the right, we actually implemented a cadence intervention to help reduce their stride length. Additionally, to another last variable that I look at related to impact is vertical oscillation, and this is how much a runner bounces. This has been a little bit more difficult to pin down normatives because it is going to be correlated with height. But for the most part, we're looking at about 6 to 10 centimeters of oscillation to be within normal limits. Taller individuals, I might be a little bit more okay with 10 centimeters. Shorter individuals, I might expect 6 or 7 centimeters. So when we look at impact and injury, so a number of conditions have come out to seem to be related to this. Patellofemoral pain syndrome, plantar fasciitis, medial tibial stress syndrome, and then on its continuation to stress fracture. And then additionally, conditions like stress urinary incontinence have also been linked with impact. When I look at movement control, I focus this mostly within the frontal plane and where the runner is within mid stance. So the first thing we look at is what is known as contralateral hip drop, which is how far the hip drops on the opposite stance leg. And seen here, and on the left, we can see an individual with roughly 20 degrees of hip drop. And on the right, we're seeing someone with less than 5 degrees. Dynamic knee valgus, which is how much the knee moves medially from initial contact through mid stance. One of the things we focus on here is what is just known as the knee window. Can I see light between the knees throughout the gait cycle, and most notably at mid stance? Seen here. And then rear foot eversion, which is a measurement of pronation. Normal is considered anywhere between 0 and 5 degrees during mid stance. And then what we see here is an individual that has more than 5 degrees versus someone who has clearly less than 5 degrees. When we look at movement control and injury, we can find that contralateral hip drop, or this dynamic knee valgus, which is really a measurement of hip adduction, is related to patellofemoral pain syndrome, iliotibial band syndrome, and medial tibial stress syndrome. Increased rear foot eversion has been associated with Achilles tendinopathy, posterior tibialis tendinopathy, IT band syndrome, and medial tibial stress syndrome. So we move forward here. I like to talk about what is mostly an academic debate, but the debate of what's more important, movement control or impact. And as you see, there's actually more conditions that clearly fall under the movement control than the impact. But there's a strong argument that by reducing impact, we actually see improvements in movement control because we decrease moments on the joints, which actually decreases demand on the musculature, which then results in often cleaner movement patterns. So by decreasing impact, we will often find that movement control improves and the conditions associated with that may actually get better. So we're going to take a step back in time. I attended my very first journal club post-professionally, my alma mater about 10 years ago, and we read this paper. And at the time, the prevailing thought, at least in my head, was that if I saw some type of movement problem, some type of aberrant movement, is that I would intervene by strengthening the muscles that controlled that movement and just assume that the rest would work itself out. Rich Willie and Irene Davis put this theory to the test. And what they did is they looked at individuals who, when running, demonstrated increased contralateral hip drop, or that increased hip adduction angle. And they put them through a strengthening program over several weeks. And they also retrained their single leg squat to improve those mechanics. And then they looked at their running mechanics and how those changed. And what they found was hip strength absolutely increased. Their single leg squat mechanics improved. However, there was no effect on the running mechanics. And so for me, this was groundbreaking at the time because it made me realize that there is clearly a difference between strength and motor control, and that also that our interventions likely need to be more specific than just strengthening the muscles that are related to those movements. They conveniently did a follow-up study where they took individuals with patellofemoral pain syndrome and who demonstrated this increased hip adduction angle demonstrated here. And they put a big mirror in front of a treadmill, and they asked them to run in front of that mirror, and they gave them cues to increase the space between their knees, so to reduce the dynamic valgus that they're seeing. And they did this over 8 sessions over 2 weeks. And what they found is that at 1 and 3 months that hip adduction improved and pain improved. So this is notable in the fact that the intervention was specific and improved symptoms and mechanics, but also that at 3 months that we saw that these mechanics were maintained and symptoms were improved, suggesting that there was a long-term skill retention. I think that's a key component about running gait retraining, is that we need to focus on long-term skill retention so that these changes can be maintained. So if you are at all keeping your finger on the pulse of the running world, I am sure you have heard of Cadence. It is a very popular metric that is looked at. Most of our patients who run also are aware of it, as most of your common fitness trackers are able to give us these numbers. And as previously stated, we know that cadence is inversely related to stride length. And so the faster your cadence or the higher your cadence at a given speed, it's going to have to shorten your stride. Brian Heiderscheit looked at this, I guess, over a decade ago, and found that increasing your cadence by 5 to 10% decreases hip loading and knee loading, decreases loading rate and peak ground reaction force, and reduces peak hip adduction. So this is a good example of an intervention that was targeting impact, but also changes movement quality. And so from what we know now is that we really have not pinned down an optimal cadence, and it's likely individualistic for everyone. I see shorter runners that may have cadences well into the 190s, and I see taller runners that have cadences in the 160s. Literature to this point has shown that maybe slower cadences or lower cadences in the 160s may leave you at increased risk for injuries, and that maybe less than 170 is less optimal for efficiency. The recent study that we finished looking at cross-country runners, we found cadences below 175 placed you at higher risk for both moderate and severe injury. So when we look at retraining this, the easiest way to do this is with a metronome. You can find these on any smartphone as an application for free. And what you're going to do is find their baseline cadence, let's say in this case 160, and then you're going to increase it by 5 to 10%. So we might increase it to 176, and then give them that new cadence on the metronome while they run on a treadmill, and this will allow them to, and ask them to sync their steps with the new cadence. And then the key component here is the diminishing feedback piece. We want to give them feedback, allow them to try the new skill, but then remove that feedback and then give it back to them, remove it, give it back to them, so they continually can check themselves over time, and this will help the long-term retention. There are studies that have shown that just one session of cadence retraining can be effective at reducing pain in conditions like patellofemoral pain syndrome. However, in my clinical experience, I do recommend that we do this over a handful of sessions so that we can really check skill retention, as well as start to consider things like how fatigue and cardiovascular threshold is going to impact their motor strategy. For instance, if you start to become tired, you're probably less likely to retain the new motor skill. And so as we start to progress within therapy, I often will try to have them run at either a higher intensity or for longer periods of time while implementing this new skill so that they can fully retain it or fully ingrain it within their motor program. Another strategy, which is honestly one of my favorites, is looking at footfall noise. And so this is the noise made when the foot strikes the running surface. And for individuals who do running analysis, I am sure they have had individuals who really just pound on the treadmill. And those individuals are usually relatively easy to recognize. But what I like about this is that we can utilize this not only on a treadmill, but running outside. And the cue generally is just land softly, land softer, or make your foot strikes quieter. This has shown to be incredibly effective at reducing loading rate, as well as we see reductions in foot inclination angle. Often we see increases in cadence, as well as decreases in vertical oscillation. And so this is a very, very easy strategy, as well as I think that we can universally say that it's something that we can apply to most runners. You really shouldn't make a lot of noise when you hit the ground. Next, I'd like to talk a little bit about vertical oscillation. This is, again, the movement of the center of mass in the vertical direction. And while this has not been studied extensively within symptomatic patient populations, we do know that from previous literature that we see reductions in vertical ground reaction forces and loading rates. And show here, we have a runner running on the left with their habitual running pattern, and then on the right, when asked to run with a low oscillation pattern, they were given the cue, run as low as you can without crouching. And what we see here is that based off my red lines, that the individual is not moving as high in the vertical direction with the low oscillation pattern. And if we look at the loading patterns off of our instrumented treadmill, you can see here that the vertical loading rate is substantially lower in the blue line, which represents the low oscillation group, and compared to the green line, which represents the habitual or native running form. Additionally, on the right here, we can see a bar graph representing the peak ground reaction force. And so in this individual, we saw almost a 200 Newton reduction in their peak ground reaction force with a simple cue. And in this case, this would probably be about 1/3 of her body weight. So as I said before, the running cue is try to stay as low as possible. But additionally, we find that vertical oscillation and cadence have an inverse relationship and are highly correlated. And so often when we increase cadence, we will also find that vertical oscillation will also decrease. And so both methods could be effective at reducing vertical oscillation. And so this is one that I think that most people will be able to adapt to relatively rapidly. So 1 to 3 sessions of retraining may be appropriate. And I consider this effective for any impact-related condition. So patellofemoral pain syndrome, or medial tibial stress syndrome, and stress fracture. And then finally, conditions like stress urinary incontinence. A recent study that we hope to be sending out for review soon, we found that that pelvic floor muscle function is highly correlated with vertical oscillation. So we're going to be looking at this as an intervention strategy for individuals who suffer from stress urinary incontinence. So now we're going to move on to some more controversial topics, including foot strike conversion. So here we have some videos of an individual who is a habitual rear foot striker, and I asked them to run on their forefoot. And so let's look at some of the differences here. So when we look at foot strike conversion, in rear foot strikers, we know that loading rates and peak vertical ground reaction force are known to be higher. This also places more demand on the hip and knee and may result in conditions like patellofemoral pain syndrome. In forefoot strikers, we find that loading rates and peak vertical ground reaction force are substantially lower, but we do see that we increase foot and ankle demand. So this may place more stress on the Achilles tendon, resulting in Achilles tendinopathy, as well as it places more stress across the forefoot, which may result in stress fractures, including metatarsal stress fractures. So if we take a moment and we look at our image on the right, this is a pressure map from our instrumented treadmill showing the difference between the left, which is the rear strike condition, and the right, which is our forefoot striking condition. And what we see is that the map gets quite a bit hotter on the forefoot striking around the first and second metatarsals on both the right and left foot. That can be visualized here. And so this brings us to an important point that when we consider something like foot strike conversion, we really need to be considering that what stresses we're placing on other tissues. And this takes time for an individual to accommodate to these stresses. And so when I look at forefoot transition, I'm really looking at least an 8-week time period, probably 8 to 16 weeks. And it's very important that we're reducing running volume. If you're a 30 miles a week runner, you can't just switch foot strikes and maintain that high volume. In reality, we're probably looking at reducing running volume to 20 or 30% of normative while we implement a forefoot striking strategy. As far as the cue, landing on your toes or landing on the front of your foot, most patients or individuals adapt to this rather quickly. But one thing that you will often find is that the individual has a tendency to increase their vertical oscillation, increase their stride length, and decrease their cadence. And so these are things that will often resolve themselves with time, but you may need to intervene here as well to make sure that they're not reducing cadence with the forefoot striking. In the literature, this is shown to be incredibly effective in conditions like patellofemoral pain syndrome, as well as the military has extensively studied anterior shin splints, chronic exertional compartment syndrome, and they've looked at using forefoot striking to reduce this. They have some cool studies where they've actually found decreases in compartment pressures with the idea that the tibialis anterior has to work a lot harder in rear foot strikers during that eccentric phase of heel contact. So the forefoot striking reduces that eccentric muscle contraction and reduces the compartmental pressure. And they've found substantial relief and return to duty in those individuals. Additionally, another controversial topic is the use of minimalist shoes. So a minimalist shoe is defined as a minimal cushion or arch support, and it operates under this idea that runners adapt to the surface stiffness that they're running on. And so when we have a big cushion on our foot in the form of a big heel or lots of arch support, we can't feel the ground underneath us. And so we are less able to adapt to the impact forces. When we get rid of that support and we get rid of that cushion, the runner can feel the ground underneath them. And so they are more likely to adapt a running posture that allows them to attenuate those forces better. And so what we see when we change runners into minimalist shoes is that we see reductions in their foot inclination angle. It seems to promote a midfoot or a forefoot strike. We also see increases in cadence, and we also will see decreases in vertical oscillation. And so this is a habitual rear foot striker running in her regular shoes on the right and then running in minimalist shoes on the left. I gave her no other cue other than just run on the treadmill, and she ran at the exact same speed. And what we see at initial contact is that her foot lands with substantially less foot inclination angle, almost to a midfoot strike. Her tibia is relatively vertical, and her knee has increased knee flexion compared to the other side. I also found that her cadence increased by around 5 beats or 5 steps per minute. So what we know from the literature looking at minimalist shoes is that loading rates do decrease, and that we see reductions in peak ground reaction force compared to traditional shoes. And this, I think could be a really effective intervention when we look at impact conditions like patellofemoral pain syndrome or conditions that might be more related to heel striking like anterior shin splints. And here are some loading graphs from our instrumented treadmill showing with the blue line that is a reduction in both loading rate and peak ground reaction force. And we have to keep in mind that this took place immediately after transitioning, and that we would likely see further reductions in loading rates with more of a habituation period. And then the other thing that I wanted to talk about with as far as minimalist shoes is this idea of potentially using them as a training tool or a training stimulus. I think historically the thought is that you would transition to these types of shoes and only use them moving forward. But there is some evidence to show that if you run in a minimalist shoe or have been taught to run barefoot, that some of the mechanics that you adopt from the barefoot running actually translate to when you wear regular shoes. And so to me, this suggests that even small periods of time running in a minimalist shoe may have positive implications for running mechanics. We also know, conversely, on the other side of this equation, that when you wear a very cushioned shoe or a maximalist shoe, that this actually increases ground reaction forces and increases loading at the hip and knee. And so the potential to use a variety of shoe types in a training cycle may actually be able to shift load throughout the body and increase overall variability within the system, which I think overall is good in a sport that actually lacks substantial amounts of variability. Additionally, there's some interesting research that has looked at injury prevention. And one of the things that has been challenging is we have very little evidence that really shows effective reductions in injury. However, there is an interesting study, or a series of interesting studies, that have looked at the use of foot intrinsic muscle strengthening to reduce injury rates in recreational runners. And another group of studies has shown that just wearing minimalist shoes to walk around over a 12-week period, and not even that often, less than 10,000 steps a day, we can see increases in intrinsic muscle strength and size. And this is a comparable amount to a foot strengthening program. And so I asked the question is, do minimalist shoes provide or facilitate stronger foot intrinsics? And does that maybe potentially result in fewer injuries? And so this would be the use of potentially using something like a minimalist shoe just for walking, and then maybe using your regular running shoe during running. However, this is some areas that we hope to explore in the future. So in summary, some kinematic risk factors that have been identified are this large foot inclination angle, generally greater than 10 degrees, cadences potentially lower than 170 steps per minute, increased vertical excursion of the center of mass, noise at foot strikes, so very loud foot strikes, and then this contralateral hip drop, probably greater than 20 degrees, or the existence or the non-existence of a knee window during mid-stance. And so when we look at interventions, I'm going to label these as our low-risk interventions: cadence, footfall, and vertical oscillation. For the most part, in the literature, we have found that there are very few consequences for these, and the fact that it is likely to make patients feel better or no worse, and is unlikely to make them feel or to increase symptoms and incapacity. A recent systematic review by Doyle in 2022 found that cadence interventions seemed to be relatively effective, and there was very few adverse events. What I'm going to label as the bigger investment overall is this idea of maybe changing foot strike or utilizing minimalist shoes. And the big thing here is we have to consider is that we're asking an individual to adapt to new loading patterns, and adapting to those loading patterns take time. And so for foot strike manipulation, I would really emphasize at least 8 weeks, as a transition may be longer in a traditional shoe. And if considering using minimalist shoes, this may take actually a very long time. I'd say at least 16 weeks, but many individuals this may even take longer. We do see that there may be an increased risk of a different type of injury in a minimalist shoe in this kind of 8 to 16 week window. So this is where we want to be incredibly cautious and make sure that we're progressing our patients very slowly and under supervision. This is absolutely not the types of interventions that I give patients and then ask them to do it on their own. I generally recommend that we're staying in contact with them and helping them manage the accommodation period. So, who would benefit? And I broke this up into 3 groups here. Our definitely category is this individual that has had repeat injuries that have just not responded to a series of conservative interventions, or individuals that just have not been able to return to running because of symptoms. Or, and I've met a lot of these individuals, people who have stopped running because of some condition. These are the people that are great for us to take a look at their gait mechanics and consider interventions, because there's really low risk, because in many cases they're not running or unable to run. Where it becomes a little bit more challenging is this probably group. We can consider some notable gait risk factors as being maybe signs that we should be intervening, but also looking at the condition. Patellofemoral pain syndrome is a good example in which, in many cases, the literature has shown that people will often have multiple bouts of this condition throughout their life. And the more bouts that you have, is the more likely you are to develop something like patellofemoral osteoarthritis. And so intervening early with a gait intervention may actually help to disrupt that cascade. And then lastly is looking at this maybe group. And where we really don't have a lot of evidence is this prevention. Can we utilize this stuff in healthy runners with the idea that we want to reduce their overall injury risk? This brings us to a really cool paper done out of Hong Kong by Chan in 2018, where they looked at individuals or novice runners, and they looked at a relatively large sample size of roughly 300. And they had them run on an instrumented treadmill, and they gave them feedback from that treadmill on their impact force, but also told them to land as softly as possible. And they did this for 3 sessions. Then they tracked their injury rates for an entire year following. And what they found is the individuals who got the intervention to land softly or to reduce their impact had a 60% reduction in their injury rates. And so this is a really good example of that, where maybe some simple interventions like run softly or land softly might be really valuable for reducing long-term injury in runners. And so I have 2 cases I would like to highlight here. This is a case I presented at CSM a few years ago. We had a 27-year-old male with chronic right hip pain. The hip pain dated back 10 years when he was running high school cross country, and then it continued to plague him throughout his college cross country career. About 3 years previous to me seeing him, he had his labrum surgically repaired. And honestly, this was a success in the fact that most of his everyday symptoms had improved. But after 3 different bouts of physical therapy over that 3 years, he was actually never able to return to running successfully. He had completed the University of Delaware's Return to Run program on 2 different occasions and was successful to start, but as soon as he would increase his volume, his hip would flare again and he wouldn't be able to run anymore. So I had he was referred to me from a colleague, and we did a quick clinical exam. We found no substantial limitations in his hip range of motion other than some mild end range pain. And then his strength indexes, which I measured with a dynamometer, I found both his hip and his knee strength to be within 10% of the other side. So when I did his gait analysis, we found that he was a rear foot striker. He had an increased stride length, and his cadence was about 170 steps per minute. And because he had a substantial history of failing to return to running, we went a little bit more radical in this case. And in this patient, I explained the benefits and he bought in. And what we looked at was using a minimalist shoe to help him convert to a 4-foot strike. And we did this over 12 sessions over 16 weeks. And additionally, I use high load strength training. So heavy deadlifting, heavy squatting, dosed at an RP of 6 or 7, with the idea of not only improving muscular strength, but also improving load tolerance of the hip. At the end of the 16 weeks, he was able to run 15 miles a week and complete a 10K race, which was his goal. And then coincidentally, he followed up with me a year later for a shoulder-related injury and found, and I asked him that he was still running pain-free. And at this time, he was using his minimalist shoes as well as some traditional road shoes, and he was still running successfully. And an additional case, this is a case that my wife and I published in the Journal of Women's Health this year. We had an individual with stress urinary incontinence, a 43-year-old female with 2 children. She had completed both pelvic physical therapy and orthopedic physical therapy, looking at strengthening her pelvic floor and her hip musculature. And she found substantial improvements in her everyday function, including reductions in leakage during daily life. However, she continued to have leaking during running. In this case, she ran 2 miles roughly 5 times a week. During her gait analysis, we found increased vertical oscillation. We found running cadence to be 156 steps per minute. And we also found that she made a lot of noise when she ran on the treadmill. So this increased sound intensity. And so for me, I went with the simplest intervention, and I gave her the feedback to reduce the sound intensity with each foot strike. And I gave her this on the first visit, and then I had her come back 2 weeks later and followed up with this. And we found on the reeval that her vertical oscillation decreased, her footfall intensity decreased, and all of her leaking symptoms resolved during that 2-week interim. And then at 8-week follow-up via email, she was still symptom-free, and her outcome measures had improved further. So here are my references, additional references, and then lastly, I want to thank you for allowing me to speak with you today. You can contact me about running-related research, or if you wanted to talk shop, at my Moravian email address, or if you have questions regarding patients or instrumented assessments for patients, you can contact me at my St. Luke's address.
If you have questions, please type them into the chat or unmute yourself and ask. Dr. Steimling, I have a question. Is there an instance where you would take somebody above that 100, 180 cadence if you felt like they were already there? Is there an instance where you would retrain them at a even higher cadence?
It's a really good question, and I have honestly never done that. And honestly, if I'm finding cadences that are in the high 170s approaching 180, I would usually look at a different intervention, like foot strike manipulation or something like that. I could see an incidence if you had an individual who was on the shorter side, because we do know that cadence is going to be related to leg length, that potentially higher cadences might be an objective for them. So maybe 190 might not be unreasonable for someone who is on the shorter side.
Great. Yeah. Thank you. Any other questions?
Yes. First of all, great presentation. Thank you very much, Dr. Steimling. At a lot of physical therapy sites, there is bodyweight supported treadmill training or unweighted treadmill training. You mentioned that in trying to get back to running or after changing your cadence or changing your footwear or your stride length, you're saying to drop your mileage. Is there any way that you would be able to utilize some of that technology to increase the rate of return or maybe just take off some of the weight while maintaining the same distance? Is there any literature on that?
There is none that I know of, and I will admit that I am not well versed in the body weight supported treadmill literature. However, I think it's an excellent idea. I think when you're thinking about really high volume runners, and this may not sound really high for a lot of people, but it is reasonably high, as 30 miles a week. It might be hard to have them run 30 miles a week on an instrument or on a body weight supported treadmill. But I do think that you have a good point that could be a really viable option to introduce someone to something new that's going to put arguably substantially more stresses on a variety of tissues.
We do have a question in the chat. What was the running volume in case 1 when you saw him a year after the 10K?
He was maintaining about 15 to 20 miles a week. But interestingly, actually, I had introduced him to some heavier load strength training, and he actually really liked it. And so he was doing actually more strength training than he was running previously. And so it was more or less he picked up a new hobby. And so it is arguably a confounding variable in that, because we do know that strength training often has positive effects on running related injuries. But in this case, he was able to maintain what I consider to be at least a moderate running volume.
And the response was awesome. Any other questions? Okay, well, thank you again, Dr. Steimling. That was an excellent presentation. Please, thank you everyone for joining in online and in person. Please remember to log in and complete the quiz and evaluation via EADS to get credit, CME or CE credit. Thank you, everyone.